Okay, good afternoon. We're going to talk about lower abdominal disorders. And this is kind of a fun topic because there is such a wide differential diagnosis. In fact, we have a long list here, which is just to make the point, not to memorize the list, that there are so many things that could be happening when someone presents with lower abdominal pain. Depends on the age, depends on the gender, so many things that could be going on. It's really easy to make mistakes. And the answer in this area is not to CT everybody, which is often sort of the default. And we will talk about when it's really important to obtain a CT scan for some diagnoses, but we'll also talk about when it's more appropriate to obtain other imaging or no imaging in many circumstances. The most common diagnosis that we make at the end of this patient encounter, where we often make a mistake, is by diagnosing them with gastroenteritis. Now, do people come in with gastroenteritis? Absolutely. Sometimes that is the correct diagnosis. But before you click on that gastroenteritis or type that in or end up at that end of that story, just ask yourself, how sure am I that that's what's going on? Because that is where we get sued. That is where mistakes happen. More importantly, mistakes happen with patients. And so we want to make sure that that's really what's going on. In this area, we want to be very careful. There are a lot of really serious diagnoses on this list of differentials. And so especially when we're talking about elderly patients, we want to test liberally, we want to consult liberally in certain populations, and we'll talk about those. Let's first start with a very common diagnosis or common consideration, which is the patient with constipation. Now, constipation can be a symptom. It's often a symptom. It can also sometimes be your diagnosis. And so when you're also ending up at a pathway where you choose constipation as your diagnosis, be very careful. Is this a symptom of something else? Because often patients who have serious pathology may have a chief complaint of constipation, or constipation may be part of their symptomatology. Now, there is no definitive test to tell you that someone is constipated. This really is a clinical history, and often you're left with it as a diagnosis of exclusion in someone where you're really not worried about other serious etiologies. Sometimes people think ordering a KUB or a plain film is going to help you or show you that there's a lot of stool there, and then maybe that means they're constipated. Don't count on that. That is not a definitive test at all. Plain films and CT are neither sensitive nor specific to make this as the definitive diagnosis, because a person could be constipated or full of stool and still have something serious going on, right? Or they could be constipated and the film doesn't show that they're full of stool, but for them that feels constipated. So it's really not something that you can test for or prove. It may be a symptom of something more serious underlying it. Now, a medication history is really important in the patient that comes in with a chief complaint of constipation. You should always inquire about narcotic use. A really common side effect is constipation. We want to think about whether or not there actually is a fecal impaction. Is this someone who really is going to have a difficult time resolving this? This can happen in patients who are really immobile, for example. There are those rare patients that do need a disimpaction, which is something we really don't want to do in just a general old ED room. You want to really think about that. And if you really, again, think that something else could be going on, we want to test liberally. Now, certainly, if someone does have constipation and that's what you end up with, there are lots of ways to deal with it. There are enemas, there are laxatives, there are suppositories. Sometimes we find ourselves asking the question whether or not we want to actually deal with this in the ER. I personally don't think that it's something that we need to solve in the ER. It's not an emergency. Often, a lot of those medications take a long time to work. And frankly, I think most patients would rather be at home in the privacy of their own home to deal with the end of that story. But really, it's kind of up to you and how you practice. Let's go to the other spectrum and talk a little bit about diarrhea, another really common chief complaint in the patient who may have lower abdominal pain. Now, certainly when you're talking about adult patients with diarrhea or patients in general with diarrhea, viruses are the most common etiology of that diarrhea that you're seeing. Now, if it is a viral diarrhea in general, there should not be blood in the stool. There should not be fecal leukocytes. Not that you need to send fecal leukocytes on all diarrhea, but if you did, or if you did a hemocult, or if you got that in the story, they shouldn't generally have white blood cells or blood in their stool because it's not an invasive type of diarrhea. Now, most adults who have diarrhea are not going to come to the emergency department because it's usually self-limiting, and most people know that, so you're not often going to see that. So you really do have to ask yourself, why is this patient here today with diarrhea? What's special about this particular case? Now, when you're talking about invasive etiologies of diarrhea, for the most part, people often come in with lower abdominal pain. Usually they describe it as crampy. They may have some fever as part of their presentation. When you're talking about invasive types of diarrhea, you may have blood as part of that story, and you may in fact have fecal leukocytes. And in terms of the etiologies there, we're talking about things like Campylobacter, we're talking about things like Shigella, talking about things like Salmonella. Each one of those bacterial etiologies has some special little features to it, which we've listed here. Now, what about the person who's been traveling, traveler's diarrhea? Now, that's E. coli, and that's the most common cause of that type of diarrhea of the person who's the returned traveler. There's a bunch of different varieties. There could be parasites on board as well. And then if you talk about other etiologies like staph, that's the classic person who had, the mayo or the kind of, bad food, and 6 hours later they get the vomiting and the diarrhea. Often there are other people who are also sick who had the same food. So teasing out the history can be really helpful here. And there's a lot of other common and less common things that cause diarrhea. But for the most part, how do you treat these patients? Getting a good history is important. Whether or not you're going to do any tests really depend on the patient and what you think the etiology might be, and whether or not you really need to get to the specific answer that you're looking for. Now, you want to think about dehydration. That's probably the thing we worry most about in patients who present with diarrhea. And you may order electrolytes because you are concerned about dehydration. But certainly it doesn't need to be a reflex lab that you order. So think carefully about labs in the patient with diarrhea, whether or not they're really going to help you or change the outcome of your management. When you're talking about kids, if there's no blood in the stool, there's no fever, again, our main focus is going to be on rehydration, because really most of these things are going to be self-limited. In terms of do we treat adults with antibiotics, you have to kind of also, this is sort of a risk-benefit thing. We certainly are trying to decrease antibiotic use overall, right? We know that we overuse antibiotics. And diarrhea is one of those areas where we probably do overuse antibiotics, but there may be indications for them. Sometimes for traveler's diarrhea, 3 days of antibiotics might do it. If you really think it's a bacterial etiology, if it's E. coli, then antibiotics certainly may be of benefit. Other etiologies, there's some controversy there about using antibiotics, anti-motility agents, so it really depends on the patient in front of you. Now, when it does come to diarrhea, we have to think about C. diff, because this is a particular etiology that we need to know about for lots of reasons. This was something that, if you look at curves of incidence of C. diff, it's really been going up over time, and we thought of it for a long time as really a hospital-acquired thing or an antibiotic-induced thing, but really now C. diff has turned into a community-acquired thing as well. Yes, you can get it from hospitals. Yes, you can be a side effect of antibiotics, but people also are acquiring it these days from the community. So not all cases are going to be associated with antibiotic use. If someone's telling you a pretty significant story of diarrhea with lower abdominal pain, this certainly has to be a consideration. And if they really are having multiple stools with abdominal pain, they have a risk factor, consider testing for C. diff. So you want to send that stool for toxin testing in patients who are really symptomatic. Now, one thing that you may not have heard is that the treatment for C. diff has changed. The recommendations have changed over the last couple of years, and now metronidazole is no longer the first-line agent for treating most cases of C. diff that you would see. Nowadays, actually, the vancomycin and this other drug called fidaxomicin have risen to the top of the list in terms of treatment options. This is oral vancomycin that we're talking about. And now metronidazole is something that we use if the patient can't take one of those two drugs. Now, C. diff infection is a real spectrum. There are patients who are asymptomatic carriers of C. diff, and there are people who will present really sick with C. diff, like need a surgical consult sick with C. diff. So I would recommend that that's an area to get others involved if you're unsure if this is C. diff. And certainly if you are going to treat it, you could always consult the CDC website for recommended treatment. Hygiene is really important. If you suspect C. diff, that is one of those patients that you want to put that contact precautions sign up on the room as soon as you think about it. Because hand washing is really important, and we are a place, the hospital is a place where we can spread C. diff, especially to immunocompromised patients. We want to be really careful. So contact precautions really important. As soon as I think about C. diff, I don't have to have the results back, but if I'm considering it, I'll put contact precautions on that room until I know the answer. And certainly this is a place where you have to wash your hands. It does not get this spores of C. diff. The C. diff itself doesn't get killed by the isopropyl alcohol, so you want to wash your hands. That's really important. Okay, let's talk about another really common etiology that we think about a lot in patients with lower abdominal pain, which is appendicitis. It's across all ages. We know the etiology is often a fecalith that obstructs the lumen of the appendix that then causes infection and inflammation distal to that fecalith. Time to perforation is related to how long that obstruction has been going on, and there are a certain chunk of cases that actually don't have any physical obstruction, that it just happens, it's sort of functional. And in fact, when you talk to patients who have appendicitis and you ask them, I commonly ask people, have you ever had these symptoms before? They'll tell you, yeah, I had something like this before, and it just, you say, well, what happened? Well, it just went away. And you think, and now they end up having appendicitis, and you think, did they have appendicitis before and it went away? And the answer is, yes, it can functionally obstruct and then unobstruct and kind of go away. That can happen with appendicitis. Now, the classic history, and of course, most patients don't read the textbooks, but the classic history is this kind of diffuse, mild abdominal pain that starts around the umbilicus, then it kind of migrates down to the right lower quadrant, then they start feeling they don't really want to eat anymore, but a lot of cases don't present classically. This is particularly true in elderly patients. Patients can have constipation. Some patients might have diarrhea, fever, no fever. Sometimes they have pain when they walk, sometimes they don't, which is why we spend a lot of time talking about appendicitis, because they're such a variable in presentations. The time to perforation varies, depends on how long it's been cooking for. And certainly when they do perf, often they feel better and their pain actually gets a little bit better. The one thing you can count on is that they should be tender. You don't have, when you have a patient who has a story and then you push on their belly and they're really not that tender, in general, that's something that's not going to be appendicitis. They've got to have some tenderness. Is it 100%? No. Like everything else in appendicitis, you can't say it's 100%. But everything else is very variable. Whether or not they have a white count, all of those things can be quite variable. Some of them will be eating. Some of them can have diarrhea. But when though you have those patients who can't really tell you a good story, we're talking about young kids, we're talking about older patients, sometimes the diagnosis can be really tough, which is why we end up doing some liberal imaging in those patients, which is okay because we don't want to miss this diagnosis. When you're talking about appendicitis in kids, this is the most common non-traumatic surgical emergency that happens in kids over 2 years old. And the perforation rate in those little kids is really high because they can't tell you a story of what's going on and how it felt and how it started. You're just not going to know that. But again, look for abdominal tenderness. Varying rates of diarrhea, constipation, dysuria can all be things that are part of the story. And the things, when you look back at cases in kids of missed appendicitis, what were the diagnoses that we made on those charts when we sent those kids home? And what you'll see is you got gastroenteritis right there at the top of the list. Again, be careful when you write that. And number 2 on the list is URI. And how could that be? I've got a kid who had appendicitis and I sent them home as a URI a couple days ago. Well, a lot of these kids come in with a fever, right? They come in with a fever. You look at them, they got a runny nose. You're like, boom, fever, runny nose. That's probably a URI. But how many kids, when you put the diagnosis of URI, did you actually press on their belly and document that they didn't have any abdominal tenderness? Well, I hope after hearing this story, you'll think, you know what? I am going to push on their belly. It's such a quick thing. Push on the belly. See if they might be tender there. Because if they are, think twice. Because a lot of kids walk around with runny noses. If they've got a fever, could be appendicitis, could be that 1 in 100 cases kind of thing. So URI is the number 2 diagnosis on missed cases of appendicitis in kids that we sent home and ended up bouncing back. Pneumonia also on the list, sepsis on the list, UTI as well. So perform and document an abdominal exam in kids where you end up calling it URI. Now, what about imaging? Where are we with imaging and appendicitis? These days, especially in those people where we're sensitive about radiation, ultrasound has really become the best imaging, the first imaging choice that you go to. Now, certainly some of us work in places where we don't have ultrasound available to us 24 hours a day. This may be limited by what your imaging options are. Totally get it. But if you're talking about a go-to for appendicitis, ultrasound is quickly becoming the best test of choice. And the more you order it, the better your ultrasound techs get at doing it, and that your radiologists get at reading it. Certainly, if the ultrasound is indeterminate, which it often is in appendicitis, although your techs get better and that number goes down. But CT is obviously your next go-to, or MRI. You're talking about a pregnant patient, you're talking about a kid. MRI is certainly an option in appendicitis, and many places have protocols to do MRI to rule out appendicitis as well. Because CT radiation of the abdomen is a significant whack of radiation. So we want to be sensitive about that, especially in our younger patients. When it comes to CT, let me tell you that although a lot of you work at places where your radiologists continue to make you give oral contrast to those patients, the literature says that you don't need oral contrast to make this diagnosis on a CT scan. And of course, how your tech does your CT scans is often dictated by what your radiologist is telling them to do. But just so you know that even in their own literature, there are papers to say you don't need oral contrast to make the diagnosis of appendicitis. Certainly, it's up to your radiologist to kind of dictate how those protocols are, but this is something you might want to take up and talk about, for example. And MRI is definitely on the list for pregnancy and kids. Now, what about management? Anything new in management? Because the old teaching was that all of these went to the OR. Well, it turns out that in the last several years, there have been papers coming out talking about non-surgical management of appendicitis. And so some of the paradigms of straight to the OR have really changed. Now, this isn't going to be up to you in the ER to decide. This is obviously still something you consult a surgeon for, but they may take the road of talking to the patient and coming up with a plan that could include antibiotics and some watchful waiting. And that shouldn't seem to you as just out of the ballpark unreasonable at this point. That might be something that is reasonable. There are patients who don't want surgery. There are patients who are high surgical risks. There are reasons that they might choose this option, and certainly some of these things are being more embraced, and there is literature to support it. So it's not a crazy idea should your surgeon decide to talk about the patient and make that decision with. But again, we're not making that decision and putting a patient with with appendicitis on antibiotics and sending them home. So this is really decided by the surgeon. It could be guided also by the CT appearance of the appendix at that point. Now, certainly, if they are going to go to the OR, we do give pre-op antibiotics. It could be cefoxitin, it could be a ciprofloxacin metronidazole combination, whatever your surgeon wants. Now, diverticulitis, next sort of lower abdominal pain thing to talk about. Really common in elderly, but boy, don't you see a lot of diverticulitis in younger and younger patients, certainly happening for sure. Little pouches that get inflamed in the colon. It's usually a left-sided thing. It can be a right-sided thing, but it's most commonly a left-sided thing. Usually, diverticula on the right side are the ones that bleed and don't necessarily hurt like this. These days, we come up with this diagnosis more and more often on CT scan. Again, done with or without contrast, depending on the institution and the radiologist where you work. And in my institution, we do these with IV contrast to make this diagnosis. Now, it used to be, back in the day, that most diverticulitis, if not all diverticulitis, got admitted for IV antibiotics. And now, we are sending people home with diverticulitis with PO antibiotics, provided that their pain is controlled, they can tolerate antibiotics, there's no perforation on the CT, and they're a reliable patient, and they can follow up if needed, and they should have a follow-up with a belly check scheduled for them. Down the road, one thing that you should put on your discharge instructions, or at least tell the patient, is that for most of these cases, it's recommended that at some point they get a colonoscopy. It's not an emergent thing or an urgent thing, but at some point they need to have a colonoscopy, because often on the CT scan, all of that inflammation, the radiologist can't really say if there's something else going on in that part of the colon, so often a colonoscopy down the road is recommended. What kind of antibiotic coverage to use? Well, there's a bunch of different options. You're basically looking at covering gram-negative organisms and anaerobes. So the ciproflagyl combination is common, although we know that fluoroquinolones are rapidly falling out of favor, and so some people are going with some other choices, which is totally reasonable. The CT scan looks for complications. That's why you do it. You're looking for abscess, you're looking for perf, you're looking for free air. It helps confirm the diagnosis if they don't have a previous diagnosis. But do I CT scan everybody who I think has diverticulitis? No. There are certainly a group of patients who have had this diagnosis before, coming in with the same left-sided pain, feels just like the diverticulitis I've had before. Provided that they look pretty good and that their exam is not concerning to me, I might send that person with antibiotics home and good discharge precautions. So not everybody gets a CT scan, especially those who've had a previous diagnosis of diverticulitis. But I think about it in all of those cases no matter what. Now let's talk about volvulus. We're going to talk about sigmoid volvulus and cecal volvulus. We'll start with sigmoid, more common of the two. This is usually a condition of older patients who are pretty immobile, often institutionalized, have kind of chronic constipation. And this chronic straining can lead to this lax sigmoid that can sort of flip over on itself, which is obviously not good. There's a classic plain film finding for this that I'll show you, which is kind of this inverted U that comes from this flipping over of the sigmoid colon. But frankly, these days, most of these diagnoses are made on CT scan because you've got an older patient, comes in with lower abdominal pain and tenderness, and there's a lot on that differential. So often it's the CT scan that gets you there. The treatment is to consult surgery, and they don't have to always do surgery on this. They can often do a sigmoidoscopy and actually decompress it that way without having to actually operate. But it depends on the case. It depends on the surgeon. Now, in terms of plain film, because some people work in institutions where you don't have access to CT scan all the time, and so plain films are still something that you use. And so a plain film for sigmoid volvulus, the classic film looks like this, where you basically have this flipped over, big dilated sigmoid colon that looks like kind of an inverted U pointing actually towards the right upper quadrant. But this is actually the left colon, the sigmoid colon, that is flipped over and is pointing towards that right upper quadrant. That's what a sigmoid volvulus classically looks like on a plain film. Now, cecal volvulus on the right side is very different in lots of ways. This is younger patients, usually in their 20s to 40s, a very acute onset of pain, and it's due not to some kind of lax sigmoid or lax cecum. It's actually a congenital abnormality where their cecum is more mobile than it should be, and so their cecum, the right side, can also flip over and cause a volvulus. The classic finding on a plain film, we'll look at it in a moment as well, but again, usually you're diagnosing this on a CT scan because in this patient, you're thinking about things like appendicitis. It's on the right side. You're not expecting a cecal volvulus, so you're often looking into other diagnoses as well. It turns out that this is the most common cause of bowel obstruction in pregnancy. And in the cases of cecal volvulus, surgery is the treatment here. That's what your surgeon's going to go to. So you see this sort of dilated colon, kidney bean-like thing. This is in the right side, kind of right there. That's what the classic plain film looks like in cecal volvulus, if that's your imaging limitation that you have and you order a plain film. And sometimes it's just quicker to get a plain film. You're taking a look. But if that's what you're looking at, that's what the classic film is for cecal volvulus. Now, we see a lot of patients who have inflammatory bowel disease. Let's talk about Crohn's disease here. And Crohn's disease is something that can infect the entire GI tract from mouth to anus, an inflammatory disorder. These are often young patients when they're first diagnosed, and this is not a diagnosis that you're making in the ED because it really requires a colonoscopy and endoscopy to take a look and biopsies, and that's usually how the diagnosis is made. But you may be seeing someone in the ER who has a diagnosis of Crohn's disease and is now presenting with bleeding and or pain, because those are common things that happen when a flare occurs. Know that in patients with Crohn's disease, we really try not to do any surgery on them if at all possible, because this is going to be a lifelong condition. This is something that can affect all parts of their GI tract. So subjecting them to multiple surgeries and risk of obstruction, et cetera, can really be problematic. So surgery is really reserved for cases where there's fistulas or abscesses or perfs, things that they have to operate on. But often they'll get admitted for antibiotics, some hydration, maybe some bump up in their immunosuppression, depending on what their flare looks like. Can some of these go home? Should you talk to their GI doctor and make some recommendations for some medication changes? Possibly, if they look good. But that is going to be all up to you. You're the one seeing them. You're the one who can clinically assess them. You have to think about whether or not they need to come in or not. If you did a CT scan, for the most part, it'll often show basically a flare, wall thickening, and maybe complications. So I want to reserve that CT for where I really think something is different than the usual flare. And it's okay. These are people who are often on immunosuppressants, and sometimes you're left with the choice of scanning them because you're not sure. And that's okay. They are at risk for complications. Know that people who have these inflammatory bowel diseases can also have things like kidney stones and different kinds of rashes and arthritis, things like that that are autoimmune in general, that can present with more than just GI complications. Ulcerative colitis also falls along this line, except that ulcerative colitis, as it states in its name, is limited only to the colon. So it is not the entire GI tract. And in fact, if you were to do a colectomy, that would really cure this disorder. Not that people would want that, but that is the case. It is limited to one part of the GI tract. These patients can also have bleeding and pain and obstruction. And again, usually we try to go just for supportive therapy, a bump in the suppressive agents to see if we can control it without doing any kind of surgery. And they can also have extra GI manifestations. Surgery reserved for those cases with complications. But don't think that having Crohn's or ulcerative colitis protects you from having appendicitis or some other abdominal emergency. And often, that is one of the reasons that we do image, because we're concerned about maybe it's something other than the flare of their underlying disease. And that is something to be worried about. They're not immune from having those other things, so it is a reasonable thing to consider. Now, patients who come in with a small bowel obstruction, let's talk a little bit about what's going on there and what the treatment is these days. So 2 common causes of small bowel obstruction. We've got people who've had surgery before, and so they've got adhesions. That's a really common cause of small bowel obstruction. And then you've got patients who actually might have something like an incarcerated hernia that could be causing it. Now, there are other causes as well. Cancer could be on the list, but it's kind of further down on the list when it comes to small bowel obstructions. It is certainly high on the list when it comes to large bowel obstructions. Clinically, patients look terrible. They're vomiting, they've got pain. If you really listen to their belly and you're taught, that on auscultation they'll have high-pitched bowel sounds, that's true. And usually these patients are going to get imaged that's going to tell you that they have an obstruction. Now, you may start with plain films, and yes, you can see air fluid levels on plain films, but a CT will give you a lot more information. And if this patient is going to go to a surgeon or be consulted on by surgery, they will often want the CT to get a little more information as to where the lead point is and what exactly is involved. So CT is really replacing plain films when it comes to this diagnosis because it gives us a lot more information about the location and what's involved. These days, most of these are not going to surgery. They will be admitted for fluids. They may or may not need an NG tube. If they're very symptomatic with vomiting, it may be helpful, but it certainly isn't required. And often, your surgeon will do a serial gastrographin challenges to see basically if that contrast is moving through, to see at what point it might actually resolve. So often, these are being watched and observed and sort of surgery reserved to see if they really need it and it doesn't resolve with more supportive type measures. And thinking about electrolytes is important here as well. Now, for large bowel obstructions, malignancy is very high up on the list. And so this is something, again, is going to be made on a CT type diagnosis. There are plain film findings here as well, but CT is much more sensitive to make this diagnosis as well. Now, most of these patients will require an NG tube, IVs, admissions, and a lot of them will end up needing surgery for this. So here are some different images, plain films, to kind of give you an idea of what these things look like. But again, for the most part, these are being diagnosed mostly on CT these days. Now, mesenteric ischemia, again, very rare cause of someone coming in with lower abdominal pain, but one of those really emergent, time-sensitive things that we have to always be worried about, particularly in patients who are at risk for throwing clots into their GI tract. Who are those patients? Those are older patients, patients with AFib, those kinds of patients, vasculopaths, that we worry about them having vascular issues in their abdomen. This is a really serious thing because you've got potentially dead bowel. And so it often can be a fatal condition. We have to recognize this as soon as we can and think about it early. Because certainly decreased blood flow to our mesenteric gut is just a really, really big deal. Now, this can be embolic, it can also be thrombotic, and it can also be just flow related. If you've got a septic patient, low blood pressures, they're in the ICU, not perfusing their gut well, they also can end up with mesenteric ischemia. But we know what the risk factors are: elderly, AFib, the person who's on DIG or medications for AFib, vasculopaths, diabetic patients, people who look really sick. We've got to think about this diagnosis. And one of the key clinical findings is the person who's telling you a lot about pain, a lot of intense pain, but on your exam, you're kind of like, oh, I'm not really finding that much, and it seems pretty nonspecific. Think about mesenteric ischemia. If you really do think about this and you think that it's what's going on, you want to call a surgeon sooner rather than later, because ultimately that may be what they need. It may be the thing that saves their life. So think about it in the patients who've got vascular disease or risk factors for this. Often on the labs, when you send the labs, they will have quite a pronounced leukocytosis, and the other lab you want to make sure you send is the lactate, because often that can also be a sign because it's elevated. Now, lactate can be elevated in sepsis and other conditions as well, but this is one of those things. You've got ischemia, the lactate will bump up. Often they have quite a profound metabolic acidosis because of the ischemia and shock as well. CT is the way to diagnose this. IV contrast is the way to go. And often you would think, I need to order a CT angiogram to make this diagnosis, but most radiologists will say, please just start with the CT abdomen pelvis, because they can often see this diagnosis in that case, and they still are considering other things as well. And so that may be the way to go in terms of CT choices. Surgery is who you're going to consult. It may be an interventional radiologist that ultimately does the trick, but often we make this diagnosis too late in the course, and so think about it early. Hernias. Let's talk a little bit about hernias, because these are common, and certainly this is one of those cases where they don't all need to be imaged. This is still a place where you can make a clinical diagnosis. In terms of the terminology, you've got incarcerated and you've got strangulated. Incarcerated means that hernia is stuck and I can't reduce it. Strangulated means that it's stuck and the blood flow is impaired, and I'm worried about it being ischemic. And in that case, if I'm thinking about a strangulated hernia, might be ischemic bowel. You don't want to reduce that in that particular case. There's a lot of different types of hernias, but some of the common ones of inguinal hernias, you've got the direct hernia and you've got the indirect hernia. One way to think about which is the two, I often get confused. The direct one is the one where it just bulges through kind of a weakness of the abdominal wall. The one that goes really into the inguinal area is the indirect hernia. You can also see femoral hernias, and these are actually more likely to incarcerate. A word about perforated bowel. Often we think about free air in the abdomen, and sometimes we think about getting an upright chest x-ray on this type of case if we're thinking about free air in the abdomen. When it comes to bowel, that may also be something you consider, but let me again say where CT is more superior to plain film here, because CT is way more sensitive in picking up air in the abdomen and certainly telling you where it came from as well. Perforated bowel is one of those things. It happens often in elderly patients. It happens in people who are on immunosuppression, and they may not have a dramatic presentation that it really impresses you clinically, and then you end up with a diagnosis of perforated bowel. They don't always have free air. They don't always have a dramatic presentation. And proximal GI perforations are often very painful and more dramatic, but bowel perforations can be a little more subtle in how they present clinically. And certainly, again, CT is more sensitive. If you do find perf bowel, you're getting a surgical consult, you're starting antibiotics, you're resuscitating that person. They very likely may go to the OR, depending on what their other comorbidities are. This is what free air does look like on a chest x-ray. You see here that thin line of diaphragm with the air underneath, and that's what it looks like on an upright chest x-ray if you were looking for free air on plain films. That's what it would look like. On CT scan, you can see a lot more. You can see little pockets of air that, and you can also still see it, you can see that diaphragm with the free air underneath. But in addition to that, you can see other little pockets of air around organs, et cetera, around the bowel, and it can be a lot more sensitive in picking that up. And that brings us to the end of lower abdominal disorders. Diane is up next. Thank you very much.